Donc, merci beaucoup pour l'invitation, toujours de vous tous les deux, organisateurs, toujours ravi d'être présent à Paris et à entendre ce qui se passe dans le domaine de, pour moi, matrice extracellulaire, mais il y a beaucoup d'autres choses dedans. Moi, j'avais fait ma thèse il y a une trentaine d'années sur les collagénopathies, les fentes de la biopalatine, Stickler, collagène 2, 10, 9, etc. et 11. Mais je dois avouer que 80% de mon temps pendant les 30 dernières années a été sur les anomalies vasculaires, même si j'ai continué le travail sur les fentes de la biopalatine. Mais donc, merci beaucoup pour l'invitation et j'espère que ça vous résonne, ces anomalies vasculaires. Je pense que le point extrêmement important, c'est que ce n'est pas du tout ce qu'on a discuté jusqu'à maintenant, mais 60-80%, ça dépend un peu de quelle malformation vasculaire on parle, se localise sur le TETECOU. La majorité se trouve dans cette région-là. But I think that it's better that I change to English for my presentation. I think it's easier for you to continue to follow me because my franglais n'est pas parfait, even if I have been in Brussels for about, well, probably 30 years. So I am localized in the Duve Institute, which is actually these two buildings here, and the Center for the Vascular Anomalies, which is taking care of my wife, Professor Laurence Boone. So it's a long-standing collaboration between these two entities, as well as the genetic diagnostic laboratory that Dr. Nicole Revencu is taking care of in the clinical genetics side. And so, just for my disclosures, so what are vascular anomalies? I don't know if you are all aware of these. There will be some images which are fairly strong. You can see that they are very, very variable. They can be very localized. On the other hand, they can be very diffuse. Any part of the body, any organ can be affected. Some of them are syndromic, other ones are not. So it depends a lot on the size and localization and the other symptoms that are affected. But you can see the problems that these patients have. Pain, very often chronic pain throughout the life. Bleeding problems, often associated with them. Dysfunction, if you have your whole arm with a big venous malformation, you just can't write anymore, you don't have muscles. If it's close to the eye, if it's in the brain, many different dysfunctions. Overgrowth, that's definitely one part, is often seen with vascular anomalies. And then the venous side, they have chronic consumptive coagulopathy, so they have thrombi, and they can have, of course, then this thrombus that can be unstable. Reduced quality of life with all the quality of life questionnaires, and so these diseases are also lifelong and really make the quality of life for these people very difficult, low. We basically characterize them into venous, lymphatic, capillary, and arteriovenous, but sometimes they are combined. But we have those four vessels, and any type of vessel can be affected. So when you have a patient in front of you, in the old literature, they were called angiomas, but now we know that there are at least 40 different types of just malformations. Then we have the lymphodemas, where probably there's 100 different subtypes. But what are the cues to the diagnosis is the color of the lesion, the intensity of the color, the extensiveness, the distribution. Also, if the lesions are multifocal or not. The aspect, is it more scattered or is it very homogeneous? Is there pain associated, or is it only when you touch it, when you palpate? What are the functional limitations, and then what are the associated symptoms? Also, was it present at birth, or did it appear later in life? And is there any family history? Moreover, when you can examine, is the lesion compressible or not? Can you push it and it pales, and then blood comes into it very quickly after you take your compression off? Is there pulsatility, suggesting that there's arterial flow? Is there pain when you palpate? Do you feel eventually a thrombus and calcification inside? Laboratory tests. Do you have anemia? Are D-dimers elevated, fibrinogen eventually low? Is there thrombocytopenia? And in some rare cases, angiopoietin 2 is nowadays a marker also for a specific diagnosis. And then, of course, genetics. I am a geneticist, germline and somatic genetic testing. And can you find eventually a mutation or a pathogenic variant nowadays? Radiology, especially the Doppler ultrasound, which can also measure the flow, and then the T2-weighted MRI to see the extensiveness of a lesion, a thrombus and calcification inside. Laboratory tests, do you have anemia? Are D-dimers elevated, fibrinogen eventually low? Is there thrombocytopenia? And in some rare cases, angiopoietin 2 is nowadays a marker also for a specific diagnosis. And then, of course, genetics. I am a geneticist, germline and somatic genetic testing. And can you find eventually a mutation or a pathogenic variant nowadays? Radiology, especially the Doppler ultrasound, which can also measure the flow, and then the T2-weighted MRI to see the extensiveness of a lesion. Into which organs, which deepness does the lesion go? We usually only see the tip of the iceberg on the skin. This is the basic classification that ISVA, the International Society for the Study of Vascular Anomalies, is revising. This has been now submitted to JOVA, the Journal of Vascular Anomalies. So basically we put them, these lesions into tumors and malformations, and then we still have this class PUVA, provisionally unique vascular anomaly, because we don't know what to call it. So they go to PUVA. In the tumors, I don't really go into those. The malformations, we then divide by the flow to those that have fast flow. So there seems to be arterial component, slow flow, and then there's the category of bigger vessel anomalies, which is not really the focus of ISVA. And then if we look at these more carefully, there's the capillary, lymphatic, venous, and combined. And just very shortly, there are many different entities below. So I'm not supposed that you would pick them up from this short presentation here, just to show the diversity. And that's why in the multidisciplinary centers, it's extremely important to have physicians from different disciplines to discuss together so that we can get to the correct, the precise diagnosis, and also to discuss which management eventually would be the best. Is it the radiologist that should do something, or the surgeon, or perhaps, now that we are entering more and more to the medical treatments as well, or a combination, and in which order? And just very shortly, so we are part of the ERN VASC-ERN. We chair the Vascular Anomaly Working Group. There are 6 working groups. And we do these patient pathways. And there are several of them now in the, on the website for capillary malformations, capaciform hemangioendothelioma, lymphatic malformation, severe rare infantile hemangioma, and venous malformation. There's also the publication and the pathway, and hopefully for these ones we will also have those soon there. And there's also webinars for the 3 of them. So the other ones hopefully will be coming up. And just to show what these pathways are, not to go into details, but basically there is the beginning. How do you do the diagnosis? What should you look at? What kind of diagnostic workup is then needed? And there are some other slides on that. And then you get to the management side, hopefully. And then there are also the treatment possibilities that are available. These are expert opinions. It's based on the European Vascular Network, but I think it's still very useful as a document. But so what causes vascular anomalies to develop? I'm a geneticist. We are talking here about genetics. It is a genetic disease. There are actually 13 different inherited vascular anomalies, and that was the very beginning to understand all the different types of vascular malformations. Some of them were not known in the medical literature, like we discovered the CMAVM 2003, and then the second one, second form of it, 2017. And all of these genes in black, so you have the disease name first and then the gene name, all of them cause loss of function, except TIE2, which actually we now know is a weak gain of function inherited mutation. And because of the fact that there were loss of function mutations, but the lesions in these inherited forms tended to be localized, small, multifocal, and localized. So not all the vessels are affected. So what are the other factors playing a role? Well, we thought then of the second hit, just like in retinoblastoma. And that, what we showed firstly 2002 for glomovenous malformation, for this one here. And after that, it has been shown by us and others for the majority of these dominantly inherited vascular malformations. But because of the fact that even the gain-of-function mutation here needed a second hit, we started to think that perhaps there are mutations that alone could explain the non-inherited, sporadically occurring venous malformations. And so, as Laurence Boone is a plastic surgeon operating these lesions, we took a series of them and looked for mutations in the Tie2 receptor. And actually, in 60% of them, in that first series, we identified a somatic, so tisular, Tie2 mutation. And since then, so this was 15 years ago, the field has exploded. Because now we could understand that the somatic, the sporadically occurring vascular malformations, which are the far majority of these, because the inherited forms are rare, there could be a somatic mutation. And of course, there were tissues in different anatomopathological laboratories. And so people have started to look at them. Proteus was associated with AKT1 mutations, Cloves to PIK3CA mutations, and then I won't read all of these. I already showed you that there are about 40 different entities. So there are lots of diseases for which we now know that they are caused by certain types of somatic genetic mutations. This series has not completely yet ended. We are still looking for new mutations. There are some patients, perhaps 20 to 30% of patients, where a mutation cannot be identified. Of course, it may be that the biopsy is not perfect, it's not representative, or the mutant allele frequency is too low for us to really pick up the mutation, because sometimes it can be very low. It's not like in cancer. It can be, very often it's below 10%, and even below 5%, and we put the cutoff to 1 or 2%, depending on the laboratory. So, very recently identified entities. One, you perhaps know Sturge-Weber syndrome. It's definitely a head and neck localized disease. There's the facial capillary malformation, leptomeningeal angiomatosis, and also glaucoma. The triad is the classic Sturge-Weber syndrome. This was identified to be associated with GNAQ somatic mutations. And of course, everybody has been looking at their patients, and then we had a couple of patients where we did not see the GNAQ mutation, and we were then looking at the patients and realized that actually their neurologic symptoms started more slowly. We had to go towards adulthood. The leptomeningeal vascular anomalies were also milder. We had to be very careful in the imaging analysis to be able to point them out. And the capillary malformation, although it darkened when the patients got older, but it was very scattered. It was not homogeneous like usually in the Sturge-Weber. In addition, the capillary malformations were much more widespread, not only on the face. They did have glaucoma, but actually they had the GNA11 mutation. So again, showing that there is variability, even in one entity which seems to be very homogeneous. Second example, again, we had individuals with capillary malformations, and we thought that they should have a GNAQ mutation, but they also had focal cortical dysplasia for this patient, or diffuse pachyuria, and also frequent epileptic seizures, so they were not classic capillary malformation patients. The capillary malformation was very disseminated, very pale, so one could also think of another entity, which is DCMO, where we have PIK3CA mutations. But we didn't have neither one. Actually, we identified an AKT3 mutation. again showing this variability in the phenotypes and the genotypes. And I think that for the management of these patients, it is very important to know exactly which gene and even which mutation they have. We are coming to that. And the last example, patients again with capillary malformations, but now associated with dilated veins. And again, the CM seem to be fairly pale, not the classic that is associated with GNAQ mutations. And when Martina De Bortoli, who was a PhD student in my lab, screened these patients, she actually found either PIK3CA mutations or PIK3R1, the regulatory subunit, changes. These were amino acid substitutions in different parts of the PIK3R1 or PIK3CA. And what was interesting in this study, we tried to isolate endothelial cells from these lesions to see that is it really in the endothelial cells that the mutations are in. And you can see here that the tissue had an allele frequency of 18% for the variant allele, whereas the primary endothelial cells from the same patient, the allele frequency went up to 50%. Here another case, 11% in the tissue, 50% more or less by Sanger sequencing in this case, in the primary endothelial cells. So at least they are very much enriched in the endothelial cells, and in some other patients we have also looked at the non-selected, the non-endothelial cells, and we see that the allele frequency there is extremely low, probably just representing the non-selected endothelial cells. So is the pathogenic variant important? PI3 kinase, the PIK3CA mutations, are definitely identified in various patients. And is there then a difference between the different types of lesions that the patients have? To put it very short, here you have 3 different types of unifocal lymphatic or combined vascular malformation: lymphatic malformation, Klippel-Trenaunay syndrome, where the combined malformation is associated with hypertrophy of one extremity, and capillaro-lymphatico-venous malformation. Cloves is a syndrome where the lesions are all over the body. And now if you look at the mutation spectrum, you can see that only in Cloves syndrome we have mutations all around the PI3 kinase, PIK3CA subunit, whereas in the more unifocal lesions, you tend to have the hotspot mutations, either the 545 or 542 and the 1047. So there seems to be, and there's statistically significant difference in the types, in the distribution of mutations, depending on the phenotype. How about then the allele frequency? Is there any clues we can get from the allele frequency in the tissue? Again, the same comparison, the lesions that I just showed. You have here the more unifocal lesions, and here PROS patients, these PIK3CA related overgrowth spectrum patients. And you can see that the allele frequency in them is higher, and this is statistically significant, compared to the unifocal, whether only lymphatic or combined lesions. Oops. And this is true in whichever way we put the syndrome, only the Cloves, only the lymphatic malformation here with all the PROS, or the different types against the different syndromic forms. So it seems that when you have these syndromes, the allele frequency tends to be higher, and kind of it fits with the fact that we think that the strong somatic mutations are not compatible with life. You cannot have it in the germline. And perhaps these non-hotspot mutations are also weaker mutations, and you can be more mosaic for those. Whereas then the ones that are associated with the very localized lesions are these stronger mutations. And there are lots of biological assays ongoing, also in the mice, to study all these. But so clearly one needs to screen the whole gene to be sure that one gets to the correct genetic diagnosing. Another question that we had is the timing then important? Could that be an explanation why patients with similar gene mutations have very different phenotypes? So here you have 2 patients with lymphatic malformation, either microcystic, so very little lymphatic cysts, or a macrocystic lymphatic malformation. And here you have a Klippel-Trenaunay syndrome, which is a combined capillary or lymphatic or venous malformation with hypertrophy of the lower extremity. All of them have a hotspot mutation, the H1047 mutation. But the phenotypes are very different. So with Taija Mäkinen in Uppsala in Sweden, so it's really her group that performed the mouse studies, we decided to induce the PIK3CA mutation either early in the development, embryonic day 11, or later on. With the early developmental activation in the mice, we saw these bigger lymphatic cavities that were formed, resembling perhaps more the macrocystic type. But if it was induced later, postnatal day 2, we only saw that the lymphatic vessels were a little bit abnormal, a little bit enlarged, but no big cavities were identified. So it seems that the timing and the mutation type and the gene, and of course the cells, the localization, all play a role in the phenotype that they result in. So what about then the pathophysiology from all these genetic data? This is an endothelial cell. Now we have those 40 diseases and all those genes that have been identified. Well, what are they doing in these endothelial cells? I mentioned the TIE2 receptor, which was the one and only inherited mutation. It's a receptor tyrosine kinase, very important for vascular development. It actually uses the PI3 kinase signaling pathway. It's the canonical signaling pathway downstream of TIE2. And here we have the various types of venous malformations associated with this gene. We have then the PI3 kinase, PIK3CA subunit, the catalytic subunit, and that is associated with venous, lymphatic, but also some of the combined lesions and the so-called PROS. And you can see here some of the examples of those diseases, and also generalized lymphatic anomaly. Some of those patients may have a mutation in PIK3CA. Downstream, we have c-Abl and AKT, 1 and 3, and mTOR. And I mentioned that proteus is associated with AKT1. And I also mentioned that some capillary malformations with these focal cortical dysplasias associated with AKT3. We are in the PI3 kinase pathway, but we have many different vascular anomalies actually on the other signaling pathway as well. Here you have FB4 receptor that by binding RAS-A1 inhibits KRAS signaling pathway. And actually, the receptor and RAS-A1 are both associated with CMAVM, capillary malformations with fast flow arteriovenous malformations. Moreover, the other proteins in this pathway are also associated with arteriovenous malformations, such as KRAS, also NRAS, or to severe complex lymphatic anomalies. And also we have mutations in BRAF and MAP2K1 in arteriovenous malformations and pyogenic granulomas and extreme rare lymphatic malformations. The third signaling pathway that is still involved is GNAQ, so these G protein coupled receptor proteins, and here we mostly have capillary malformations, also the Sturge-Weber syndrome that I mentioned, and congenital hemangiomas. So here you start to have the full picture of the variability in the field of vascular anomalies, and although there are pictures from different parts of the body, you can also appreciate that many of these are in the head and neck region. So we talk about rasopathies. I think that's a term that is already very well known, but we also have started to talk these as picopathies, homologous to the rasopathies, and perhaps we should start talking here about some kind of a GNA pathies for this part here. All the mutations, I think, somehow activate these pathways. Many of them have been shown in other cell types, but now also in endothelial cells. Many of these proteins have been studied in fibroblasts and in many other types of cells, less in endothelial cells, but I think it still holds true in the vascular endothelials as well. And that, of course, is of interest because there have been, of course, developments to inhibit these, especially in the field of cancer. These are the major signaling pathways that are also implicated in various cancer types. Rapamycin, mTOR inhibitor, miransertib as an AKT inhibitor, ponatinib as an ABL inhibitor, alpelisib as a PIK3CA inhibitor, trametinib and selumetinib as MEK inhibitors, vemurafenib and dabrafenib for BRAF inhibitors, and also bevacizumab and the different lenalidomides or lidomides as anti-VEGF molecules. And these are just a few, but these are already in clinical trials or eventually already approved in the field of cancer. So this has moved us very quickly to the thinking, not just to understand the pathophysiology, but could we make models and could we try to treat those models with these inhibitors? So very shortly, I will just talk about 3 models that we've been using. The very first was with Elisa Boscolo, with the group of Joyce Bishop in Boston, that we decided to put some endothelial cells that we were using in vitro with the TETECOU mutation. We injected them into nude mice under the skin, and you can see that the mutant cells created lesions that had connected with the blood vascular systems. They were red. There was clearly blood in them, whereas the wild-type cells could not do this. We also created a mouse line where we conditionally could induce the expression of the mutant KRAS. So now we are in the complex lymphatic anomalies or AAVM side. In this model, we only induced the expression in the lymphatic endothelial cells. And we got a phenotype that mimics some of the complex lymphatic anomalies. I mean, only showing here one. You can see that the Evans blue dye here has leaked out from the thoracic duct in the mutant mice, whereas in the wild-type mice, the blue color is nicely inside the thoracic duct. We also, this was Hanong Nguyen in my lab, induced the same mutation, but now in the vascular endothelial cells. And here we didn't see the lymphatic phenotype, but what she started to see was various abnormal vessels in the brain, in the intestine, also here in the liver. And the longer the mice were kept alive, the stronger the phenotype became in these mice. Clearly showing that we can mimic, if we induce expression of these mutations in endothelial cells, we can get phenotypes that are similar to what we see in human beings. So we then decided to see if we can treat these mice with the medications that I showed in the previous slide. If we take the TETECOU mice and the first medication that we used, rapamycin. Why did we choose rapamycin? It's an extremely well-known medication. It has been used for years, many, many years, so we know the side effect profile. It has also been used in children because of transplantations. So it is also safe in children. You can see here that the growth curve of the mutant lesions in these mice goes on as time goes on. This is only 2 weeks here, 3 weeks, 20 days. But if we start sirolimus, the growth stops almost immediately. It's statistically significant in 4 days' time. And so only in these 20 years of time, there was only a tiny reduction. We can't really see if the lesions would start reducing in size later on. In the KRAS models, we used a MEK inhibitor, so from the other signaling pathway. Here another phenotype that I didn't show in the previous slide, but when we have the KRAS expressed in the lymphatic system, we don't see these white spots. They are actually lymphatic valves. They have disappeared. They do not develop. If we use the trametinib inhibitor at the early stages, we can rescue the development of the lymphatic valves. We then looked at the vascular model with trametinib, again, the same inhibitor for the same mutation. And here you can see, actually on the last row, that we don't see these lesions that we see in the non-treated mice, or if we still see some, they are very small in size and very infrequent. Again, demonstrating that the MEK inhibitor can reduce the appearance of these lesions in this model. And this, of course, then gave us the foundation to think and start clinical trials. And the very first one was with the slow flow, because we started with the TETECOU mouse with the subcutaneous lesions, and we had very nice results with the sirolimus. So in the same paper, actually, in 2015, we demonstrated for these 6 patients. At that time, we didn't know that 3 of them had a PIK3CA mutation. We only knew the 3 that had a TETECOU mutation. But they all had very complicated vascular anomalies that had already been treated by sclerotherapy and surgery, and still their quality of life was very reduced. So they were really looking for any kind of help they could have. So we tested sirolimus for these 6 patients. And you can see here that those that had this chronic consumptive coagulopathy, the D-dimer levels in the 1-year follow-up, 12 months, they reduced quite rapidly. We also saw that the pain started to go down. This is with the visual analog scale, or VAS. Quality of life with the quality of life questionnaires in the 12 months follow-up went up. And also MRI measurements, which volumetric measurements are complicated, was also statistically significant in the 12-month follow-up point, only with these 6 patients in this pilot trial. And so then, of course, because of this and the model, this was a proof of concept that we can do human treatment using these inhibitors if we are targeting perhaps correctly the pathways. And so we did a little bit bigger trial with 19 patients with slow-flow malformations with sirolimus, again with promising effects. And then we started the VASE trial, which is Vascular Anomaly Sirolimus Europe, with several centers, also from France, with 250 patients that have been recruited over the years of 2016 to 2023. And very shortly, we published 223 in JHI Insight, the interim results, and we can see that 75% of the patients have benefit from sirolimus, and this benefit comes already at 1 month. It goes a lot up a little bit more between 3 and 6 months, but it is definitely sustained. But this also means that we have 25% that do not benefit, so of course we still need to continue research. And it is also important to understand what kind of patients there are. There are lots of questions. How long should they be treated, etc. But definitely, sirolimus is very efficacious, and the side effect profile is very mild, the most important being the aphthous in the mouth, which are fairly big, especially at the beginning. Otherwise, the side effects are fairly mild, as with any medication where people may have some headache or they can have some gastrointestinal feelings. But we also have that with placebo treatments as well. Just an example, here you have a girl with a facial lymphatic malformation. You can see how big it is. You can also see it here in the MRI. In 1 year sirolimus treatment, you can already see here the difference. And here you can see the MRI, how the volume of the lesion has shrunk enormously. This is another one, again 1 year of treatment, and you can see how this skull lesion has diminished in size in a very significant manner. Also, I mentioned that Laurence is a surgeon, and especially the lymphatic malformations, there are often problems with healing because the lymphatic system does not function well. Here you have one lymphatic malformation that was operated and the not so nice result. But then she has started to put sirolimus because at the beginning, everybody says that sirolimus inhibits wound healing. But actually, in the context of vascular malformations, it makes it better. So even if something is said in the notice that it's even a contraindication, it's not necessarily true for the disease that you're studying. And now she really likes to have the patients on sirolimus even at the time when she's operating. So they are put on sirolimus before the surgery is being done. How about then the fast flow? This is the area which is the most complicated in the field of vascular malformations. We have many patients for which we don't have much to offer. Basically, there are no medications until now for these patients. So we started with thalidomide. It was one of the molecules that I mentioned. Many people get very uneasy when one talks about thalidomide because of its famous or infamous name from the 70s, because of all the children that were malformed because the mothers used it during pregnancy. So it's a very potent drug. These patients cannot be pregnant. They have to have a pregnancy test every month. And if they become pregnant, they have to stop, and they should not become pregnant. So we selected, or we enrolled 18 patients in this trial. They all had stage 3 or 4, which means that the AVM is already fairly far. They even have cardiac problems when they have the stage 4 AVM. They all had chronic pain, bleeding in 60% of them, functional constraints in half of them, chronic ulceration, meaning that the ulceration is present all the time. There's no way to get the skin to be healed. Aggravation despite embolizations that interventional radiologists would be doing. And so refractory to the current treatments that we can propose to these patients in a tertiary interdisciplinary specialized center. The thalidomide treatment that we gave, duration in this study was about 2 years and minimum 4 years of follow-up. So this was published 2022. Pain scale, the VAS scale, it was at the level of 8 to 10 for the majority of the patients, none of them under thalidomide. And you can see that the 0-3, which there was none at the beginning, 17 out of the 18 now had a pain scale of only 0 to 3. Scale going from 0, none, to 10, insupportable. Bleeding, it stopped in all the 11 who had bleeding. Ulcerations healed in all 8 patients who had the ulceration. Congestive heart failure, which is the stage 4 AVM, it resolved in all 3 patients who had it. This is a patient that we had been following also fairly long time, and actually at one moment, because of the localization of the AVM here, close to the eye, actually she wanted to have it operated. So she went with Laurence to Boston and was done there with Laurence and Dr. Mulliken, John Mulliken. And there was a very nice result of the operation. There was nothing anymore visible in an arteriography, 6 months of post-operation. But we know in the field of vascular anomalies that these lesions tend to recur, probably because we haven't moved all the mutant cells. There's just no marking available to know where all the mutant cells are. 2 years after, she started to have signs and symptoms again, and you can see that the AVM has recurred. It was not considered reoperable, so we suggested to her, adult patient, to start thalidomide, 100 milligrams per day, and here you can see about 2 years after, no AVM present anymore. And she is now 8 years without any symptoms. It has not recurred. She has stopped the thalidomide after the 2 years, and there has not been a recurrence ever since. I think the next one is a very strong image, so those who don't like strong images, even if it's from the face, which is for you. This patient has been followed for a very long time. It has been really a tough time for us to try to help her. You can see the ulcerations everywhere. It's very difficult for her to even just use a straw to eat and drink. And it's been very difficult to do anything for this patient. Thalidomide, you can see under 2 years of therapy how all the ulcerations that she had everywhere they have all healed. The skin and the mucosal membranes are now normal. And that, for her, has been a huge difference in her life. She can now much more easily eat. She doesn't have the chronic pain that all these ulcerations cause. So she now can think to live further, because some of these patients think of other options. And this is something that I like to show because it's easier also to show. It's not as difficult as the previous one. But this lady had had an amputation of one finger because the AVM was on the finger, and it was considered cured, which oftentimes we like to say it's cured, we've taken out the malformation. But a couple of years later, she came to our center because she started to feel symptoms, and of course the skin was now already completely abnormal and ulcerated, painful. In the MRI and arteriography, we can see clearly an AVM that has now recurred here, but much more proximal. So the management options are fairly limited, and one of them could be a more proximal amputation. So we suggested to her, because this was really a trial, we didn't really know, to try thalidomide. 2 years after, again, you can see the healing of the skin, no ulceration, no infection, pain has gone, and you can see here there's still some activity present. It's not she's not cured. And what we try to now do is to try to lower the dose, because we think that thalidomide is very effective. But we start with the 100 milligrams. If we start with 200, it's too much. They will get neuropathies and side effects. We start with the 100 milligrams and follow every day so that we get the maximum effect. And after that, we start to lower the dose. And for some of them, now we go to 50 milligrams every second day. So trying to get to a level where we can manage still the lesion. And we are still wondering, could we stop and then perhaps restart if the lesions and symptoms occur. And that's what we are doing in the VASE trial, actually. After 2 years of treatment, they have to stop, and then we follow the patients after that. But I didn't have time here to talk about that. And then the last example, which is more recent, a complex lymphatic anomaly. Here you can see a young boy who, from the first year of life, had had respiratory infections, growth retardation, lymphedema, pleurocentesis, and accumulation of liquid in the thoracic cavity, pleural effusions, pulmonary infiltrations. Aggravated dyspnea, you can see that he's under oxygen supply, and he had been treated with interferon and bevacizumab, the earlier medications that were available. We then decided that because these patients may have a PI3 kinase, they may be picopathies or they may be rasopathies, that perhaps we should try sirolimus, which is the safest of these medications. And so we put him on sirolimus, and you can see here that for several months he was on even high dose of sirolimus without really a great effect. So we said, okay, perhaps this patient is a rasopathy, and we moved then to a MEK inhibitor. He was on that for about 6 months, and you can see that the daily need of oxygen supply, even if it was here 24 hours and was reduced about 12 hours during this time, the forced expiratory volume really didn't change. So he was still very much dependent on the extra oxygen supply. So then we decided with Emmanuel Serron, who's our hemato-oncologist, adult hemato-oncologist, that why don't we mix these two drugs, try to inhibit the two pathways at the same time, but with a smaller dose. And you can see here the effect. You can see how the oxygen need has reduced to a couple of hours per day, perhaps 2 to 3 hours, and the FEF has increased to near normal levels. But we give these two medications, only 1 milligram of sirolimus and only 0.5 or 1 of trametinib, and alternating days. One of them one day and the other one the other day. And we have now another patient where we have had the same situation. So it seems that at least in some cases, we should try to inhibit both pathways. As we know that those two pathways, they are not only working in parallel, but they also crosstalk a lot in between them. And so people were afraid that if we do this kind of a combination, there will be more side effects. We did not see that, probably because we lowered the dose. But then people were saying, if you lower the dose, you won't be efficacious. But probably the efficaciousness here becomes from the fact that we are inhibiting both pathways. So this is a new kind of a proof of concept in the field of vascular anomalies. And the very last one, I don't know if you heard about this one, but I mentioned that we started our sirolimus trials from adults. We then moved to children because it has been used in children. And then we were confronted almost 10 years ago with this couple who came to our center for a second opinion. And she was pregnant. And the fetus had a huge lymphatic malformation around the head and neck. And clearly this malformation was growing and growing and growing. And so there was really severe concerns as to the viability of the child and the problems at birth. So with lots of discussion with on the ethics side, with the parents, we decided, and the parents wanted to try, that the mother takes sirolimus, and we will try to see if it has any effect on the lymphatic malformation on the fetus. You can see here the maternal serum level of sirolimus. Here you have the cervical lymphatic malformation size, and here you have the fetal serum level from sampling, from fetal sampling. And so you can see that as soon as the serum level in the mother went to a high level, about 1/3 of it was also detectable as going into the fetus. And as soon as this was the case, the lymphatic malformation started to reduce in size. She was then born. She still had a residual lymphatic malformation, which has then been operated and also treated with sirolimus at the early years of her life. And here you can see her at about 6 years of age. And actually, we waited to publish this until she was at school, and we saw that she started normal scholarity, not to put something into the medical literature too early, since we are in a new setting using therapy during in vitro growth. But she's doing very well. She's following normal scholarity, and so this has opened also the doors for various in utero treatments, and we know now that there are already dozens of children that have been born with the same medication. So here you have Laurence Boone and Emmanuel Serron, who's the hemato-oncologist in our center. So I think that this is convinced that we can start from patients. I think we all study patients and different diseases. We go into these tedious, time-consuming in vitro studies. We can start to understand the pathophysiology. Hopefully we can create models. We often also collaborate with groups that do zebrafish models. It's very nice in the field of vascular biology. Mouse, of course, is extremely important, even if there are many activities to try to inhibit the use of mouse, but I see them also running on the street, and I don't really understand why we could not use that as a model, because it's extremely important to get to medications, new medications, to people and patients who are in need. And so we can get to clinical studies and eventually then to novel treatments. What we are facing now, one of the problems, at least in our field, and it's we are in the field of rare diseases, and it's not necessarily what the pharmaceutical companies are very much interested in and trying to get the indications for this medication. It's another struggle and another field of activity that now needs to start and be pushed forward. So with that, I think the conclusions are probably fairly clear. I've been talking for a long time. I hope you got the message from all that. I rather like to show the people. So this is the group that I'm heading in the Duvy Institute in UC Louvain, and this is the multidisciplinary center that Laurence Boone is coordinating in the Clinique Saint-Luc in Brussels, And we are part of the reference network. And this is actually part of the reference network. We have 17 groups in Europe. And this was luckily we had an EGPRD funding for a one-shot meeting where we could invite more than just the leads, because I have a feeling that if we only always see the 34 leads, all the different people in the HCPs don't feel necessarily that they are part of the big network. And of course, there's a role for the patient associations, which is extremely important. And here, Maria Barea is the representative of the patient association. I think there should be somebody else also there, but there are so many faces, and I don't see where Caroline is. But Lex is at least there, also a patient association advocate. And if you are interested, so the website, of course, has lots of the information that we are producing. And if you're interested in vascular anomalies, the ISVA meeting is in Paris in about a month. Thank you for your attention.
Merci beaucoup. Thank you very much.
Merci.